Rightio. So, thank you very much. So I'm a GP actually in Newcastle, but I work with the GP Synergy research team 1 day a week, and they have an ongoing cohort study, which is where this data is being drawn from. So today we're just looking at antibiotic prescribing for acute respiratory tract infections by GP registrars, and with a focus on the rural and remote areas of Australia, and the use of what's called delayed prescribing. And just these are my collaborators, which are a broad array of people. And I guess the Parker McGinn he's the gentleman that runs the research unit with GP Synergy. And I just wanted to acknowledge the foundation, the RACGP Foundation, that provided the funding to support this project. So I guess it's no surprise to people that antibiotics get used more than they should do in Australia for respiratory tract infections, and I just thought we'd put some numbers around that. So the Safety and Quality Commission in 2016, they reported that over 30 million antibiotic prescriptions were dispensed in the community, and that's for non-pneumonia respiratory tract infections, the majority of which don't get any improvement or benefit out of antibiotics. Now, 88% of those were prescribed by GPs, so it actually puts GPs in a fantastic position to influence and improve antimicrobial stewardship in the community. And that rate of prescribing has been the same, it's the highest level since they started collecting data, and the rate's been pretty constant from 2009 to 2014 when that report was done. Just to put it into context with countries overseas, so in Sweden and the Netherlands, which are very low rates of prescribing for these infections, Australia's at more than double those. So consequently, people have gone and done some work. What can we do about trying to reduce this? And so there's a Cochrane review which has been done looking at randomised trials, and the sort of strategies break out into a group of three. One which is called immediate prescribing, which is self-explanatory. You see the patient, you give them a script, the intention is they go away and they start taking that medicine. The other is no prescribing. Once again, you see the patient, you give them advice about how to care for themselves and explain why antibiotics don't offer any benefit. And delayed prescribing, which is a halfway house where you're thinking you don't really need antibiotics for this infection, but for whatever reason you're concerned about them, and so you'll say, look, here's a prescription for antibiotics, don't start them straight away. If you get a lot worse in the next few days, or if in a week's time you've got no improvement, then think about starting them. So these, the figures here, these are absolute reductions. So what they found was with immediate prescribing, 91% of patients would go away and actually get antibiotics and use them. So not everybody, but almost. But if you used no prescribing, it reduced the number of patients that used antibiotics by 79%. So there was still a rump, around 12% of people who would go and get antibiotics from another source. And then delayed prescribing was almost as good as a reduction. And so 62% reduction is like an absolute reduction from 91% down to 23%. So it's a very effective strategy. Now, consequently, though, one of the drivers of why antibiotics get prescribed is because of uncertainty or fear of a bad outcome. And so to look into, is no prescribing, is a delayed prescribing, are they safe strategies, even though that's what the guidelines tell us we should do? There's a very large cohort study that was reported on last year and was conducted in the UK amongst GPs in the UK, and they recorded data at the time of consultation, and then that was followed up with outcomes for the patient over the next month. And what they found was that and they were looking for bad things, so death or hospital admission, and they found that there was no difference between the three strategies. The rate of those bad outcomes was less than 1%. And more interestingly, that when delayed prescribing was used, that actually reduced the number of people that felt the need to come back to be reassessed or because they were worried that they were deteriorating. So from that, what our aim was to just see how often do registrars use delayed prescribing for these non-pneumonia acute respiratory tract infections, and work out the prevalence and any associations, particularly with a view to what was happening in rural and remote Australia. So there's an ongoing cohort study amongst registrars. It's called the RECENT study. It's Registrars Clinical Encounters in Training, and it collects data about the practice, where the registrar is at, about the registrar themselves, and then a time point during each of their 3 training terms, they collect data about 60 consecutive consultations, and that includes the medicines they prescribe, and what we ask them, if they prescribed an antibiotic for whatever reason, for them to indicate what their intention was. Was it to be used immediately, delayed, or those two? And of course, if there was no antibiotic, then there was a no prescribing. Those registrars are throughout New South Wales, also Eastern Victoria and Tasmania. And the way we analysed for the associations was using this technique called multivariable logistic regression. And the respiratory tract infections comprised upper respiratory tract infection, acute bronchitis and bronchiolitis, sore throats, otitis media and acute sinusitis. And the data was collected from 2016 to 2017. So with the results, we had 631 registrars involved, a really good response rate of 96%. Just how that the registrars themselves, just looking at how their demographics balanced out across the different prescribing strategies, it was pretty much the same in each category. So 60% were female, regardless of whether no, immediate or delayed, and that's representative of the overall registrar cohort, which is basically 60 to 66% female. 80% were full-time in each category. Once again, that's the same as the overall cohort. At 90% were qualified in Australia, and that the mean age was 31 to 32 years. And the practices where they were located. So the majority of them were large practices with more than 5 full-time GP equivalents, and that the majority didn't routinely bulk bill patients. And the actual distribution geographically was very similar to the distribution of the Australian population. So 70% in major cities, 23% in inter-regional, which is slightly more than the Australian population. Is about almost 20% of the population live in inter-regional. And then 7% practices in the outer regional, remote and very remote areas, which is a bit less than what the Australian population is, which is around 11 to 12%. So we collected 7,156 presentations that suited our criteria, and then just looking at the overall numbers, the vast majority of those were the no prescribing strategy was used, so 68% there, immediate prescribing at around 23%, and then delayed prescribing in 9%. But if we then go to look under the covers a bit, and through this, I'll go through each of the different infections, and at the top here you can see I've got this estimate of the expected range of antibiotic use. Now that's based upon some marvellous work that was done by a group in Queensland, and what they looked at was data about the prevalence of the different respiratory tract infections that we know from the BEACH project in GPs, and then looking at the electronic therapeutic guidelines and looking at each of the different recommendations about the variations of presentation where you would use antibiotics, where you wouldn't use antibiotics. And then that's come up with an overall estimate of how often these infections present, and then what number would be expected to have prescriptions done for. So we can see here that 6 to 13% of, if you look at all of the respiratory tract infections, you'd expect antibiotic use. And with our cohort here, we've broken out into these 3 columns, so the light grey being the major cities, the dark grey being the inner regional areas, and the green being what we're interested in, the outer regional, remote and very remote. And so overall, we can see that yes, no surprise, more prescriptions are being written than it would be recommended. So it's up in, if you added the delayed and immediate together, you're up in the 30% sort of range. But not a great deal of variation between the different areas. So upper respiratory tract infection, this is probably a great story because the vast majority of infections that present are upper respiratory tract infections, and the GP registrars are doing a fantastic job. And 90% no prescriptions being written, very, very low immediate scripts, and equally low delayed scripts. With the bronchitis, acute bronchitis, once again the guidelines tell us antibiotics don't offer any benefit, so there's no point in using them. But the actual practice is quite the opposite. You can see there that once again very little variation between the regions, and that if you add the immediate and delayed scripts together, more than 2/3 of people are being given prescriptions. Otitis media. This is one of those conditions where there are circumstances where antibiotics are recommended, so an expected rate of 20 to 30%, but you can see that we're actually using upwards of 70% if you add the two different script approaches together. And with sinusitis, similarly, it's a much lower expected rate of antibiotic use, but we've got a very high use of antibiotic prescriptions. And then finally with sore throats, once again, the expected use 19 to 40%. And I guess just to explain those ranges, this is where they've taken the sort of the lowest estimate of how often these things present according to Beach to the highest estimate. And a similar story, significantly higher use of antibiotics for those infections and what would be recommended. And I guess if we're looking at those graphs, and I've been saying that there's not a lot of variation between the different areas, and that's just sort of eyeballing it, but there is some where you go, that's quite a bit lower, so in the delayed prescribing on the bronchitis there, and that sort of variation, there's very small numbers in there, so there's a wider margin of error in your estimates. So what we were able to do is we go and do the multivariable logistic regression, which eliminates a whole bunch of things that can confound the results. And the recent study collects a large number of variables that it can use to do that. And what we found that was, according to the remoteness area classification, there was actually no associations with choosing one particular antibiotic prescribing strategy over another. So how rural you were wasn't influencing in any way what approach you took to your patient. It was you see the patient in front of you, you're making your assessment, and you're basing it on their how they are. So what we do know is that GP registrars overall prescribe less antibiotics for acute respiratory tract infections than GPs. So that McCulloch study, 57% GPs will use 57% of the presentations they'll prescribe for, and the registrars 32%. And that's reflected in each of the individual illnesses that we've just been through. But the registrars are still prescribing a lot more than what are recommended by the guidelines, and that there's no association between remoteness and what prescribing strategy they've used. But the outer regional and remote and very remote practice areas, it's impacted by factors that affect access to care. So the urban GP who can say, look, you're okay at the moment, but if you feel you're not doing well in a week's time, come back and see me. That's not necessarily an easy thing to do. So we also know that delayed prescribing is a safe approach, and it's also effective at reducing the overall consumption of antibiotics, and really that's what's important. It's not actually important how many prescriptions we write, it's how many patients go away and fill those scripts and use them. So really what we think this is telling us is that delayed prescribing is a strategy which could be used a lot more extensively in outer regional, remote and very remote areas by the GP registrars, and that they could still be feeling that they were practicing safe medicine, even when they're looking at their patient and they're thinking, well, this could go either way in the next few days. So that's the end of my chat. Has anybody got any questions? Yes?
Do you think, so the delayed prescribing group was almost as good as you said, the no prescribing, so they didn't fill their script 60-70% of the time?
So they were absolute reductions. So essentially, if you use the no prescribing strategy, that Cochrane study says 12% of people go away and get a script somehow. If you use a delayed prescribing strategy, then 23% will end up having taken an antibiotic. So
Part of that is because there's more education when you do the delayed
I absolutely do. And there's other findings which we've reported elsewhere, essentially where the positive associations with using delayed prescribing are that the consultations are longer. And the reason for that is that more time is spent in explaining things. Yes. So yes, better education. So the patient understands how to look after themselves better and what to expect and when to expect to be getting better. And we've done a randomised trial, we've done a clinical trial where one of the focus was on communication methods to pass that across to the patient, and it showed it was an effective reduction in use of antibiotics.
And also, like, if the patient feels they've been listened to, so they often come in wanting antibiotics, and if you just sort of say, no, you don't need them, then they feel they've not been listened to and go and get an appointment with somebody else, or come back in a couple of days and say, I'm much worse.
Yeah.
So it's sort of giving them that power to sort of, one, the doctor did listen to me, and they said that even though I am sick, I probably don't need antibiotics, but I've got the choice.
Yeah. So I see this as you get your purists who are, but delayed prescribing doesn't make any sense. You're giving the wrong message to the patient. You're saying to them, you don't need antibiotics, but here's a script just in case. But we've got to remember that our patients, they've got an expectation about how sick they are. And the particular phrase that always comes up, I was doing okay, doc, but it's gone to my chest. They're coughing up some phlegm. And we know that antibiotics aren't likely to make any difference to their recovery with that if they don't do the other things that they need to do. So because of that, if you talk to people, you explain what's happening, they get engaged with their healthcare better, and that'll gradually, what you would hope is that the community will start to go, oh, I tried that and it worked. And then next time they won't be expecting antibiotics, and you might be able to say, well, let's not even do a script this time.
Have we ever thought about, because I feel like a lot of the problem, I don't know if it's true, but I feel like a lot of the problem is that the doctors often know that antibiotics are not going to be used, but maybe they're tired of arguing, or I've had patients come in and they get antibiotics over another doctor and just start saying how bad or whatever they are and that they shouldn't be practicing and they're terrible.
Mm.
Like, have we thought about maybe educating the public on a grand scale so that that takes that other side of things?
I'm sure people have, I can't remember. I think I've actually seen some public health campaigns, but there's nothing on a large scale on that front. But there's, what we've done is a very small piece of research, and it's in a group of people where it's very important because they're the doctors who are coming out to fill the spaces as people retire, and so it's a long game. That will change, but then there's multiple levels higher up into government and then to the world where people are constantly working on how can we change this process. So that's my time. Okay, thank you.
Strategy comes unstuck a bit when you've driven 3 hours to get to the GP because the delayed script doesn't work. They drive 3 hours back home again. They're not going to drive 3 hours back in a couple of days' time to get their script. So,
well, see, from that perspective, I would have no issue with the patient going and getting that dispensed because they're going to have that problem. They take the antibiotics home with them. That doesn't mean they actually take them. They can have them sitting there on their kitchen counter, be looking after themselves, and then if...
That's the area to educate them.
Yeah. And that's where, because this is, it's not a one-size-fits-all. We put this delayed prescribing label on it, but how it's delivered is down to each individual clinician in the context that they're practicing in. Like so much of the rest of the medicine that we practice, a guideline is just that. It's just a guideline. How we deliver that care to our patients is what matters.